Brian, this morning you asked me about pulling up our slides. Are we going to go back and forth between our slides? And I guess I better look at the agenda because that tells me who's going to be who we're following. Never mind.
Yeah, I just thought I would, if you could pull up and share the slide deck just for our two presentations, that would work. I just figured I'll be facilitating right up to that point. So, hi, Maggie.
Hello.
We'll get started in a few more minutes.
And Kimberly, I'm here by phone. I do not think I will be by camera, just phone.
Okay, thanks, Kimberly.
Thank you.
And for those of you who just joined, we'll still get started in a few more minutes. It's always awkward repeating that, but it's all good. I've learned to live in awkwardness. It's kind of my comfort area. Cindy, don't.
I'm not saying a word.
Come on, Brian, fill up the awkward silence.
I know. Just a few more minutes of me giving awkward updates before we'll get started. We want to give people a chance to join. I think technically the OHA policy is to schedule meetings for 5 after the hour, but I figured if we schedule it for the top of the hour, but don't start till 5 after the hour, hopefully that's the same outcome. Okay, we'll get started in another minute or two. Hey, Veronica.
Good afternoon, everybody.
Good afternoon. Okay, I think we can get started. I'll just do a kind of a slow introduction and give people another minute. So first off, welcome to our annual combined Pmac and Coordinating Council meeting. We, as is typical in years past, we have a lot of folks attending today, and we'll cover a pretty wide variety of topics. I think due to the number of topics and just the extended time, we will not do general introductions today. We will just jump right in. Second, we've provided a link to the meeting stream through Microsoft Teams, as well as a call-in only option. Please use only one of those choices for your audio and consider muting on your end when you're not participating or speaking up. We have a packed agenda. I'll review the agenda in just a second, but first I wanted to share a couple of general comments from the top. As I kind of hinted before, we've invited Pmac and the Coordinating Council this meeting, as well as OEB and PEB staff. Today, I asked all the audience members to please speak up, ask questions as we go along. One of the primary purposes of this meeting is to get all of our committee members and even staff who are interested kind of at least at the same baseline set of knowledge about PEB's business. Okay, so in addition, we are recording the meeting, and this will be helpful if we would like to review it later. Okay, moving on to the agenda overview. Again, it's a pretty packed agenda today. I will speak just for a couple minutes about, what I think the overarching themes of 2022 has been. We'll spend 30 minutes going over the year in review, where we will have Maggie from Mercer present our health equity accomplishments dating back a year and change. And then Teresa and I will share some accomplishments from our committee work over the past year. We'll then spend 45 minutes having Dr. Stephen Nelner from Mercer presenting our current thinking on how we can strategically implement the PEB member well-being framework. And again, I urge people to speak up and participate or to ask questions as we have these presentations. And then Dr. Nelner will also present information related to two shorter-term priorities and assignments that board leadership would like us to work on this fall. And that includes increasing behavioral health program engagement and identifying and finding ways to increase certain utilization of preventive services. We will then spend the last hour and 15 minutes going over kind of our PEB 101 presentations. And this is really what I was talking about when I had mentioned setting a baseline level of knowledge amongst all invitees. We'll cover a lot of high-level information about PEB's business, so everyone at least has that bare minimum baseline level of understanding. This information will include presenting certain insurance concepts, like what is, a fully insured product. We'll present information on member demographics, diagnoses, and utilization. That presentation will be a little more dense with data, as is usually the case. I will attempt to explain how PEB's budget and finance works on Ali's behalf, who's our director and also our resident expert on the state budget process. And then Cindy will give a snapshot of our open enrollment communication plans. So the first substantive item on the agenda is for me to cover the themes for 2022. And I wanted to just start off talking a little bit about these themes and efforts that we've all undertaken the past year or so. And I feel they dovetail nicely into the next discussion regarding our year in review, and as well as what we'll do looking forward. At a high level, I think the overarching theme for really the end of 2021 through 2022 has been to better coordinate our wellness efforts between the two committees, which I think has been a pretty large accomplishment. And I think this theme and accomplishment is evident in our recent recommendations related to EAP services that went before not only both our committees, but ultimately resulted in Stephen Nelner from Mercer, Teresa, and myself splitting up a coordinated presentation to the PEB board. And I also think that this theme and this coordination efforts are evident in the work both committees and Mercer has put into developing the PEB member wellbeing framework up to this point that it's been developed. And then last, I think overarching all of this work that both committees have undertaken and accomplished is also all the efforts the committees and staff and Mercer have put into setting up a health equity infrastructure that kind of overlays all this. So besides all of our accomplishments, we've also set up a health equity kind of process and infrastructure by which our work can kind of flow through, which is also a huge accomplishment, and is also a perfect segue into our next agenda item, which is the year in review. And we will start with Maggie. Maggie's going to present some information on what we've accomplished over the past year and change, really going back to the board retreat. So Maggie, are you going to share and present on your end?
Yeah, thanks, Brian. Are you seeing the PowerPoint now?
Yes.
Perfect. Great. Well, hi, everyone. For those of you I haven't met before, I'm Maggie. I'm an associate consultant at Mercer, and I sit as the project manager across both PEB and OEB. I've also started working on the health equity work group that PEB has established. And in the past, I think you all, in relation to this work, may have heard from Michael Garrett, and he was our fearless leader up until earlier this summer. And now Christy, who is also on this call, and I, along with the health equity work group, are taking the lead on this work and this journey, and we'll be presenting today. So Christy, if you wanted to introduce yourself briefly.
Great, thanks Maggie. Hello everybody, my name is Christy Ewing, and as Maggie shared, I'm with Mercer on our total health management team. And I joined the health equity work group back in, I believe, April. And it's been a great journey, and I'm excited to present to you today.
Thanks, Christy. So first, I wanted to give some background on the health equity work thus far with a little summary. So the work began in late 2020. There was a board retreat that talked about guiding principles, creating a work group, building strategic pillars. They talked about various aspects of health equity, including defining it, prioritizing certain populations through this work, and creating a framework to analyze various programs and decisions moving forward. The board also discussed, obstacles to doing this work, developed their strategic pillars and initiatives, and then ultimately came up with a final state, which is a health equity vision. Then I will move forward and talk a little bit about the guiding principles. So PEB has some health equity guiding principles that include promotion of health and wellness through consumer education, healthy behaviors and informed choices, as well as providing accessible and understandable information about the costs, outcomes, and other health data so members can make informed choices. And these fall under the governor's vision for addressing social determinants of health and equity. So throughout the process, the board worked on defining health equity and agreed with the Oregon Health Authority's definition, which says that Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. And so while they were doing this work as a board, they reviewed some of the various resources on health equity that are already at play in the state. So that includes OHA's work, as well as Healthier Together Oregon. And for the Healthier Together Oregon review, they decided that they agreed with the prioritized populations for health equity work. So the groups that they wanted to keep in mind as they were working through health equity impacts, and that includes BIPOC and AIAN folks, people of low incomes, people who identify as LGBTQ+, people with disabilities, people living in rural areas. And then additionally, the board identified a few other groups, including veterans, people living in multi-generational families and homes, women, and then people with visible and invisible disabilities. The board then discussed some of their assumptions and values. So there are 6 of them, including that racial and ethnic minority populations have substantial health, access to care, and social determinants of health challenges that can be overlooked when looking at data as a whole. That there are inequities in population health outcomes that are primarily the result of social and political injustice and not lifestyles, behaviors, or genes. That addressing health inequities means addressing differences that are not only unnecessary and avoidable, but also unjust and unfair. That equity must intentionally be pursued as a strategy. It will not necessarily happen as a byproduct of other efforts. That health is broadly defined as a positive state of physical, mental, and social well-being, not merely the absence of disease, and that everyone has the right to a standard of living adequate for health, including nutrition, education, housing, medical care, and necessary social services. Through all this work, they built the key health equity strategic pillars. The strategic pillars include the stakeholders involved in the health equity work, which includes members of the board, the health authority, elected officials, the benefit carriers and vendors, health systems providers and staff, as well as your consultants, so that includes us. That they want decisions to be made based on a health equity lens. So policy and operational decisions will include health equity principles, both at PEB and among all the other stakeholders involved. They finalize the prioritized populations list, discuss 3 strategies to measure health equity, and that includes various quality metrics. And then lastly, determine some long-term benefit strategies and additional action items, which included building the health equity work group, which is a small group of folks that work together to analyze various policies and decisions with a health equity lens. So I will then turn it over to Christy to talk through some of the specific pillars and some examples of the work that the work group has done so far.
Great, thanks so much, Maggie. Maggie had shown before just the stakeholders that have been identified in these health equity initiatives. And so this just talks a little bit more about stakeholders, and each stakeholder kind of has a different responsibility in the advancement of health equity. At the top here, members. And so, really, most importantly, the voices of our members, and including a focus on the effort of increasing the diversity of member committees and councils, and then also having communication channels for input that are safe and that people feel that they can share their voice. And so, as I said, each stakeholder group, having a different role that they play in the advancement. And so, for example, applying this health equity lens, for the board is, in regards to policy decisions. For OHA staff, operational decisions, having this health equity lens. And then, an example for like health systems providers and staff is that they're having health equity as part of their governance. They're having clinical protocols that take health equity into those protocols. And then also enhancing health equity for patients and staff and training is all included. So let's move on, Maggie, to the next. So from here, what I'd like to do is dive a little bit more into so the decision making with using the health equity lens. And so a couple things you'll notice is that proactive solicitation of input is really the first step, and having that channel and having member councils and committees present their recommendations, bring things forward that could possibly impact health equity. Secondly is a tool. And so we do have initial health equity tool. And so using this tool and applying it to policy and operational decisions to kind of be able to weigh pros and cons. And then thirdly, in this decision making is then additional input. So, having what is the impact of certain decisions that have been made, certain policies put into place, and having input from, again, member committees, councils, really all of the stakeholders into the impact on health equity.
And Christy, I was just going to mention that both the council and Pmac have contributed a lot in these specific areas. The equity tool that I forget what we call it, the equity analytics tool that we've developed originally was an analysis tool that Pmac developed And then when we picked up health equity as a priority, Mercer worked with us to kind of beef it up with the health equity stuff we needed to look at. And then that was further vetted and taken through Pmac and the coordinating council. And then also just, I think if folks were to listen in on the council and committee discussions and conversations over the past year, I think it's evident that we are moving this stuff forward. We're asking, who do we need to talk to? Are there member groups out there that we need to reach out to? You know, all these things are things that I feel both committees are actively doing and have contributed largely up to this point.
Great. Thanks, Brian. All right, so Maggie, I'm going to move on now to the next and just talk a little bit more in depth about the health equity screening tool and the applications. And so on the left here, you can see, so the tool categories and applications. So the categories is organization. So if whatever the health equity tool is being applied to is from an outside vendor provider, what are the values of that organization in regards to DE&I and health equity? Does the solution focus on identifying and addressing health inequities? Presence in Oregon. And then the next category are these health equity categories. And so each of these categories, which are members, communication channels, social determinants of health, health inequities and health equity, prioritized populations, evidence-based, outcome measurement, and then additional worksite wellness considerations. Within the health equity tool, under each of these categories is a subset of questions. And I think what we found so far when applying this tool is that those subset of questions then do kind of generate another set of questions that a lot of times will go back to the provider or to whatever we're applying the tool to and be able to ask more questions. Then the last category here is just additional considerations. And so this goes to costs. So what would be the impact on future premium costs? And then are there any other costs related to possibly implementation of the tool? And then the last piece under additional considerations is implementation. So also taking into consideration anything that legally should be considered. And then if there's additional support that's needed for implementation and then communication. And so the application of the health equity screening tool, in general, it's meant to evaluate the impact that a policy or operational decision would have on health equity. And so then initially, the use of this tool is that it is a checklist of sorts, and that we take this tool and this list of questions and checklist, and we apply it against whatever it is being asked to look through a health equity lens. And then again, a lot of times it generates these more questions. We can establish pros and cons and then be able to make recommendations from there. Long term, the tool is going to, hopefully it will be evolving over time, and then we will be able to add in a scoring methodology. And so that it can really be, having a score, and maybe some categories are more weighted than others. And we'll learn more and more about that as we apply this tool. And so having that methodology, so where there is a threshold that says this is the level that we need to have in order to know that health equity, the health equity impact that's in place. And so next, Maggie, let's move on to, so just to give a few examples of where the health equity tool has been applied. The first one here is breast reduction surgery. And so the work group analyzed the medical necessity criteria for reduction mammoplasty. There were 3 types of member groups that were who may qualify for breast reduction surgery. And so these are women with breast cancer, cisgender women with other medical indicators, and then transgender men as part of their gender affirmation treatment. We've also used the tool looking at diabetes prevention programs. We're in the process actually of going through with 3 now identified DPP vendors, going through this health equity lens and applying the tool. In a gender non-binary identification, we took the health equity tool, looking at the implications of systems allowing for gender non-binary members to openly identify their gender. And then also an upcoming topic that we've started working on are excluded services. And so looking at those excluded services through a health equity lens. And for example, this is like varicose vein surgery. It is a TMJ surgery. So just taking this health equity lens and applying it to these exclusions that to see if there are any health equity impacts that we have not considered previously, so that we can then make recommendations from there. So as Maggie shared before, that ideal future state, and so the PEB board agreed, with the Healthier Together Oregon's health equity vision. And so really for this ideal future state to happen within all groups that have a vested interest in health equity, really need to have intentionality around hearing those voices in the prioritized populations. Our focus is to ensure that we're transparent in our work being done, that we're asking continually for feedback and alternative perspectives from many different voices. The health equity work group, we recognize that we don't want to do our work in a silo, but rather in conjunction and collaboration with other Oregon health equity efforts and stakeholders. And we're hopefully doing this through sharing in groups like this, and recognizing that this is an uncharted journey and that we are definitely paving this path forward together, and seeing where it takes us. So thank you.
Thanks,
Okay.
Christy, and Brian, we'll turn it back over to you.
Thank you.
Do we
And I
see it? Is
think,
there a question there in the chat there?
yeah, I think one just popped up.
Emily's, under an evidence base, is there room for emerging best practices, especially as it relates to AI and AN and tribal communities and communities of color who tend to have less evidence base than for white communities? That's an excellent point, Emily. And one of the things that is an issue that we in PEB talked to Michael about before he left our work, Michael Garrett with Mercer. And so we did come up with some other ways to look at practices that didn't meet that standard of evidence base. And that's on our, I know I've shared that, I think, with Maggie and with Christy here, since they are our new staff from Mercer working on these issues with us. Those are on our topics to discuss in the health equity work group, so that we have a better understanding of some of those other ways to look at evidence and traditional practices that aren't necessarily captured in research.
And I believe the way the tool currently, or the way it currently frames it, is really open-ended. It's just, is this proposal or consideration supported by evidence? So it gives us the flexibility to look at, emerging evidence, community standards. But as Teresa mentioned, we still have some work to do on defining those things.
Mm-hmm. Consensus-based was another term that came up too. So those are all things that we're definitely aware of.
And I think that's what I was thinking of when I said community. So Teresa, I apologize. I think that's what I was thinking of when I said community-based. So I will retract my statement.
Great. Good to hear that those conversations are happening. Thank you.
Any other questions for Mercer on the health equity updates? I definitely want both committees to feel some sort of sense of accomplishment up to this point, because both committees have contributed a lot to get to this point. Emily?
Yeah, I just had a really basic question that I put in the chat early on. Just when the reference to BIPOC, I just wanted to make sure that Asian American, Native Hawaiian, Pacific Islander communities, and even Latinx are included within that language.
I think I would probably
are we using BIPOC because that's the term that OHA is using? And I think it is meant to capture all of those groups, Emily. But if you have a different understanding,
actually, I know the general public likes to use BIPOC, but OHA actually doesn't like to use BIPOC because it's not specific enough to different communities. So in general, they tend to favor like culturally appropriate, culturally specific, culturally and linguistically, because sometimes BIPOC, it ends up just being about Black communities, and then all the other communities kind of get left out. So, I mean, that's a conversation we're having at OHA. But in general, our OHA leadership has recommended that we be more specific instead of using BIPOC. But I know the general public uses BIPOC, you know, and so that was just a clarifying question
And
about
that's
how
good to know.
Mercer, yeah. Mhm.
It's helpful because I think even though we just presented our accomplishments, that doesn't mean any of the work is actually done. I mean, really, this is a journey.
Yeah.
And we'll continue to, you know, develop this material. We'll continue to evolve too. And part of that evolution are these types of conversations. And I
Okay,
see Veronica,
thanks.
you have your hand up.
Yes, I wanna talk, Emily, I am glad that you brought up that because I was just going like, oh no. Yes, people of color also include all the groups, but guess what? Majority of the groups don't want to be identified on the one box because then we lose our individuality. So at Department of Consumer and Business Services, we decided that we're going to identify each individual as themselves, you know, Asian American, Black, Latino. So it's a safe place to go that way. Latinx, Latino, Latina. So be inclusive. With that, we will be very inclusive. And we can look at the governor's DEI roadmap to equity. And it's in there, it's described as all those groups. So, thank you.
Perfect. Thank you, Veronica. Okay, so now Teresa and I will share a few of our committee specific accomplishments. Teresa, do you want to pull up that document?
My connection's a little spotty here, so hopefully I will not lose my internet.
In that case, I think I can still do it. So
I've got them pulled up here, so let's just see if it goes to screen share. Okay, now I'm having trouble.
okay, I can share. Do you want me to try to sharing it?
Well, let me see if I can figure this out. So I selected screen share and I've got two screens that I can choose from.
Typically, I think you want to choose the window option in the specific window you want to share. If you share the screen, it'll share everything on your actual screen.
Yeah. Can you see that?
Yes.
Pmac
Yep.
Accomplishments, does that show up?
Yep, I think you just want to maximize it and it should be good.
It is maximized on my screen. I don't know how to do it then, sorry.
That's all right. You can scroll down the slide as we present. I think that's fine too.
Okay, I just stopped sharing though. Can you still see it?
I'll go ahead and share.
Okay. Yeah, I'm not good at this
Sorry
at all.
about this, everyone. Okay, I'm just going to pick the right document really quick. All right. So do you guys see that up on your screen? Is it, you see the whole slide? You see the whole slide then, or is it too big?
Too big. Some of the words are cut off.
There we go. Is that better?
Perfect.
Perfect.
That worked.
Okay, sorry about that little bump in the road, everyone. Okay, so I will start off by sharing just a few Pmac accomplishments, and then we'll turn it over to Teresa. So first and foremost, Pmac wrapped up its long-term HEM recommendation work. We presented Pmac's vision for HEM to the board and got a great reaction and support. This will continue being a topic of our ongoing conversations with Mercer as we prioritize future RFPs. So this is something that we will pick up at some point in the future, but was a huge accomplishment. We also, as I previously hinted at, Pmac teamed up with the Coordinating Council to develop some EAP-related recommendations, including Pmac recommending that EAP engagement be counted as 2 health actions under HEM. And then on top of that, as we just covered, is all of the various health equity work and discussions we've had that led to us forming a work group and developing a health equity analysis tool that we could use for potential proposals and program modifications. So with that said, Teresa, I will go to the next slide.
Thanks, Brian. So as we've already talked about, the partnership with Pmac is a major accomplishment. Prior to this year, Pmac and the council worked very separately and in silos, as did Brian and I. We were kind of in our own 2 worlds, operating and staffing these 2 committees that had some overlap, but we hadn't really done any intentional work about addressing that. So many conversations and lots of examination resulted in what we now think is a really good working relationship between these 2 committees. Some of you recall that last year, Brian and I brought to you what our initial thinking was about how our committees could work together. Some of you on the council remember that I had been challenged with how to keep the council engaged and focused on worksite wellness, because the worksite had changed because of COVID, and the worksite now included many, many, many employees working remotely who would continue to work remotely. So that, in addition to agencies kind of struggling to implement their 2-year wellness plans, which didn't really fit anymore since COVID had changed the worksite, meant that I was really challenged with how to support agencies and to support the council with this new world. So when Brian and I brought our initial thinking to you and you said, yes, that looks good, we brought a couple ideas to you, you liked them, we took them then to Dr. Neldner, who fit them into this much larger framework, which is the well-being framework that we've been focusing on for the last few months. Other accomplishments that the council can point to are contributing to and approving the health equity screening tool. The council came up with some ideas before the tool was even approved to examples of worksite wellness scenarios and policies that could be run through the tool, just so that we could get a feel for how the tool worked in that respect. So that was one thing that the council contributed to in that respect. And then recommendations from the HERO Scorecard. If you want to go to the next slide, Brian, the HERO Scorecard is something that PEB has done for several years, and council members were invited to participate in completing the scorecard, and I believe 1 or 2 members did participate in that work group. The key recommendations that came out of the HERO Scorecard were to focus on strategic planning and organizational and cultural support, to develop a written multi-year strategy and tactical roadmap to execute the strategy, and to vet the plan with interested parties at all levels and request feedback on challenges and possible solutions. And that is exactly what the framework, that's where we're at with the framework. That is focused on strategic planning. It is a written plan. It has a roadmap, and the council has seen it and contributed to it. Pmac has seen it and contributed to it, as has the PEB board. So next on the agenda is Dr. Neldner, who's going to help us look at moving that strategic framework forward.
Thank you, Teresa. And Dr. Neldner, welcome.
Thank you. Hello, everyone. And
Greetings.
Katie, my colleague, is going to help project the slides for me so I can concentrate on the slides. And this is going to serve as an update on that framework that Teresa just referenced. We, just for a reminder, as you recall, we've been in front of this group a couple of times and have shown you that broader framework, which included as its first phase, discovery. So over the last several months, and you're aware of this, it's just for refreshing our memories, is that we've been involved in inventorying what the various carriers and the EAP have to offer in terms of well-being services. So that process of inventorying those services has been completed. Of course, it's never ending because those services continue to grow and expand, but we're in the next part of that discovery phase, in the framework phase, to continue to promote those services and opportunities for the membership. And that is going to intersect with this next major section of the framework that we're going to talk about today, and that is the strategic planning part. And we're also going to talk a little bit about ongoing work for both of your committees. So the well-being framework has taken us to this point of now gathering a group of key representatives to help develop this multi-year well-being strategy and roadmap that Teresa just referenced. Some of the things that we're thinking about as we constitute this group that's going to work on the strategy, and the goal of the group and overall outcome of the group is to consider some of these factors that we have listed here. First of all, governance. So who will be responsible and accountable for the impact and the outcomes of the well-being strategy? And clearly the PEB board is responsible for that from the PEB side at least. And OEB may join this process too. As you'll see, we're going to be inviting some representatives from OEB. But at least for now, PEB board is going to be the primary accountable and responsible party, and of course its designates.
And two, just to hold out to the council and PMAC, if you guys have different thoughts or just have questions about this, please do speak up. So all of these decisions about the strategy development are not made decisions. This is our latest and greatest thinking that we're hoping you can react to. So if you have opinions one way or the other about, doing this, please don't hesitate, raise your hand, or just, speak up and let us know what you're thinking.
Thanks, Brian. So again, in that vein of offering you some suggestions and some ideas that we have right now as to how we can formulate this working group for strategy, we think that the optimal group size is somewhere around 10 to 15 representatives. And the reason that we know that that works pretty well is because we want people around the table to have a voice and to be able to be heard and to contribute. And while we'd love to have hundreds, if not thousands of people, unfortunately, that's not a manageable size. So we will hope that the representatives will echo the voices of the many. And you'll see how we've tried to develop some representation from different groups within the suggested participants below. Another point about who we're looking for and what the role of these individuals will be. This will not be a decision-making body. It will be more of an advisory body. And those individuals that are serving as representatives should have some good awareness of the organization from a variety of perspectives. There's no one person that has full perspective of every agency, of course, but that's why we're looking for people who have some representation and understanding of many different perspectives. Those individuals should have some circle of influence, if you will. So they should be people that are recognized among their peers, that are people that are concerned about the health and well-being of others. They may have positions of authority by virtue of their role within the state organization, but not necessarily. That's not a prerequisite by any means. We want the voice of many to be heard and considered. And of course, we want people to be expressive and engaged in the conversation, but not dominating. And so you can see below that we have a sample of some of the kinds of representatives and the interests that we think could fit into this optimal group size of 10 to 15. So Clearly, we want representation from Teresa and Brian from their roles with the council, and of course, Teresa being the wellness manager for organization-wide and representing OHA. Brian staffing Pmac. We have Sharna and Ruby from the Health Equity Work Group. You can see we're recommending that you work and that will come out of this process with 2 people representing the council and Pmac that could be identified by your interest or some selection from your peers or from the leaders of your groups. We hope to invite 1 PEB board member, 1 OA board member, and then a PEB management representative and a representative from HR from the CHRO's office, Representative Das as well. We'd like to engage 1 to 2 health equity professionals that are already employed by the state, and then a policy expert from each of PEB and OA. So here's another chance to pause and get your reaction to those suggested roles and kinds of individuals we might be including in this.
And just to note, Teresa and I will ask for committee members to volunteer, and not necessarily today, although you can let us know today, but potentially think about it and email Teresa and I if you're interested in serving on this work group. I think initially, and Stephen, please jump in if I go kind of off our intended kind of the path, but I think we envision this occurring over the course of this fall. So we'll need a little bit of time to plan it, but I think September through December is probably a reasonable framework when maybe the most intense part of the work will happen. Again, we'll ask for committee volunteers. And also we'll get to this during the next part of the discussion that Stephen will facilitate, but in that discussion, we're going to be looking at some short-term priorities that we're hoping will also take us from September to December. So we'll have, our hope is that we have, 1 or 2 members from each committee participating on the strategy development work group. And at the same time, our 2 committees will work on some other shorter-term priorities. So all that said, though, committee members, you have questions about what this looks like, concerns or ideas? Does this hit the mark in your mind?
And maybe, Brian, I could, I think that's a good segue. Maybe before we get reactions, I can move to the next slide and talk about the timeline, because that'll help give more context around what the expectation for those volunteers would be. So as you said, Brian, it's probably going to take for the rest of the year. You'll see the timelines that we put on this slide are really the best case scenario, but you can imagine with 15 people and the Mercer team besides coordinating this schedules of up to 20 people, it's going to be a bit of a challenge. So we're giving ourselves a little leeway and grace to be able to take this a little bit longer than the ideal time frame. And that's why we have the footnote at the bottom. Timing is subject to availability of team members and other things that might occupy its members' time. But you can see that we're in the very first stage right now of identifying, recruiting, confirming representatives. Then we will be setting and scheduling the meetings in advance so people can know and have placeholders for those meetings throughout the next several months. And Mercer will be developing strategy discussion guides. So Mercer will be facilitating these conversations. For those of you who are going to be part of this group, we will be giving you guidance on what areas and what topics we're thinking about, talking about pros and cons of different approaches. We'll be using some word clouds and word suggestions to help prompt thinking. We'll even be doing drafting of some preliminary vision and mission statements for you to react to, so that we'll help with the heavy lifting, and you'll just be able to tweak and fine tune and express your opinions about things as we go along. So we'll have a kickoff meeting about a month out. We'll introduce the representatives to each other. We'll review the Hero Scorecard results that Teresa referenced earlier, because we'll use the opportunities that were identified in the Hero Scorecard as the foundation for the development of the strategy. And as I just mentioned, we'll draft a mission, vision, and goals document, some guiding principles for our work, and then we will get started on the work. We'll have a subsequent meeting where we really dig into reviewing what we've summarized from the mission, vision, and goals and guiding principles, and then actually start to put flesh on the skeleton, if you will. And Mercer will draft reactions and summary from that meeting, and we'll bring that to a third meeting. And there we hope to finalize the strategic planning. When I say finalize, that means finalize the draft, because all of this is going to go on for review, socialization, and obviously presentation and approval by the board. But that's the general flow. We're expecting that these strategy meetings will be about 2 hours each, 2 to 3 hours. We'll set that cadence and time duration, but just to give you a sense of what the time commitment would be for participation in this group. Then, of course, from the broad strategy, we'll also develop the tactical roadmap, and then we will be sharing that, as I mentioned, with partner groups. We'll make revisions based upon feedback from those partner groups, and the strategy group will reconvene for that, and finally present to the board for approval. So now that you know a little bit more about what the commitment might be, reactions. Hey, I see a question in the chat there. Let me get to that. Couple of questions. Okay, so Emily suggests consider adding a tribal representative who can help to represent Oregon's 9 federally recognized tribes. So we certainly will take that back and see how that can fit in. Kelly says, is it possible to attend and not be on the committee? The strategy discussion would be helpful for Uplift to hear. And I leave that to Brian and Teresa to react to.
Yeah, I think we could vet it. I think one consideration, we want this to be a pretty candid and frank conversation, a work group where people feel comfortable speaking up. So one consideration is we do not want it to be a public meeting. We want it to be kind of a nice, private, people feel comfortable. So if we do allow other folks to participate, we'll or at least attend, we'll need to stay within those parameters. But I think Teresa and I probably need to take this back to our leadership to feel what they're comfortable with in terms of the number of people.
Thanks, Brian. And Gayla asks, how will you plan to solicit information from agencies and ERGs and others? So the first reaction is that we've started that process already. As you know, we've gathered input and had those discussions in the previous Pmac and council joint groups. Emily certainly has been a great contributor to that, and we've really appreciated her input, and others. So the door will not be closed. I don't know how, and we'll talk about this in the organizing meeting about how we can make representatives who are serving on the strategy committee available to others who want to provide their input. I think that's a way that we could incorporate that. But we certainly don't want to close the door to any ideas and suggestions. Realizing that at some point in time, we've got to coalesce the ideas into something actionable. Otherwise, we could be spinning our wheels for some period of time. So we will be action oriented, but that doesn't mean we want to close down any discussion or any input that we could get from interested parties. Is that a fair reaction?
I think so.
All right.
But what about the committee members? What do you guys think? Good. Okay. Yeah. And then Kelly, getting back to your request, it also seems to me Uplift may be in a different situation where maybe the conversation with leadership is whether you guys should just be on the work group. So maybe the context isn't really, do you want to invite others, but maybe it's just Uplift being a representative on the work group. So we'll follow up with you offline after we have a chance to talk to leadership. Other thoughts, comments? Knowing that Teresa and I are at some point going to ask for volunteers, is there anything else you guys need to know to figure out if this is something you're interested in? Okay. You can always follow up with Teresa, Rebecca, and myself after the fact. So Feel free to email us if you have additional information you'd like to share, or if you just want to chat offline.
Okay.
Stephen, I think that brings us right to the next agenda item. And just a note, I'm looking at the agenda. We will take a break. And I think for this item, we have 30 minutes. So I think that that should actually be fine. That will leave us with about a 6 or 7 minute break to still stay on the agenda. So I think we are good.
Excellent. Thanks, Brian. So this goes to the point that Brian made earlier, is that while the, excuse me, certain representatives of Pmac and the council will be serving on this strategy committee, we want to be able to have something meaningful for Pmac and the council to continue to do throughout the rest of the year. So some parallel work, if you will. So we've got a few ideas that we're going to share with you today. And let me first of all say that these ideas came right from leadership. The first idea is coming from Ali, and the second from Shaban, the chair of the PEB board. So, and to Brian's earlier point as well, these are not set in stone. We're giving you these ideas as something that you might choose to work on. If you have other ideas that are more burning for you and you feel more passionate about, we're open to those as well. But these are some ideas to prime the pump, if you will. So the first suggestion that Ali made is, can we find a way to increase engagement in the behavioral health services that are offered by various carriers? And one that we know here, and we're going to show you from the 3 different carriers, Providence, Kaiser, and Moda, what they have to offer. The first one that we're looking at here is the Behavioral Health Concierge Program that's offered by Providence. And just a brief description of what it is, it's really a direct line 800 number to speak with a care liaison who can schedule a same day or next day appointment to have a video conference with a licensed mental health professional. So really the idea is to provide very quick access for people with behavioral health needs. And you can see on the right, the graph shows that there has been, over the last 12 months, and this was through June of this year, that the number of people who are accessing the service and the number of visits that they've had has continued to increase. So probably a need. But while we say that, you can see one of the bullet points under considerations is that while it is increasing, it's still below Providence's book of business. So there's still more opportunity to get more people involved. We know people of this pandemic era that we've been in and are still living through has exacerbated existing mental health and substance abuse problems, and probably initiated some more. I won't say created, but that's for further debate. But the idea is that we know that there's a lot of need in the population. So you can see that this might be a good solution for some who are in Providence, but it will only serve the Providence population. That's why we're also going to take a look at the other carrier services. And we really would like to see if you have any interest in picking up on this. Before we do that, let's go to the other 2 carriers and show you what they have. As you know, as most of you probably know, Kaiser Permanente is an integrated health system, and they have behavioral health consultants that are actually part of the primary care team and work in tandem with the primary care providers. They also have health coaches that can provide telephonic support to work on other related healthy behaviors that can contribute to mental health, such as stress management and sleep deprivation. They make available various mobile apps that can help individuals go their own self-guided path to do mindfulness, meditation, other behavioral health support. You can see the listing there. And then they also have peer support specialists who can offer peer support related to mental health and substance abuse disorders. You can see also on the graph on the bottom that utilization continues to increase for PEB, and it is higher than the book of business for Kaiser Permanente's commercial book of business, and has ramped up from 2020 through 2021 and continues to increase into 2022. So clearly more engagement and more individuals as well. Moda behavioral health services on the right side of the slide. They offer outpatient, residential, and inpatient mental health and substance abuse disorder services. You can see they have licensed care coordinators. They also partner with community mental health programs and refer people to those. And they also offer a few apps. Utilization there, you can see MODA has about 18% of PEB membership, about 3,000 members who have been engaged in some form of outpatient behavioral health service in the past year, and 200 MODA PEB members engaged in the Muru app. And then they have relatively low uptake of members who are engaged in that coordinated specialty and pain program so far. So they're expressing that there's opportunity to get more MODA members involved in their services as well. So that was a quick overview, but just to set the stage for the discussion and give you some background. And the next slide is just going to pose some ideas and discussion to prompt a discussion among you and us to see if this is an area that you might like to consider. And you can see that the first question is, do you think it's worthwhile? I'll just mention all the questions here and you can pick any of those that you want to react to. And some of the other things that might be of interest are, what do you perceive to be the issues to be with the current behavioral health services from any of the medical carriers? What are you hearing from your colleagues? And that is ERGs, interest groups, just water cooler talk or virtual water cooler talk. And are there differences by agency, by location, job type, and things like that? And then we also offer some ideas that might prompt some thinking about how, if you chose to embrace this particular activity, some things that you might consider as ways to increase engagement. So we have some time for your reactions, and we'd love to have a very interactive dialogue here. And again, while you still haven't seen the other version now, if you have some early ideas about other ideas that are not just this, but might be related, that you might be interested in, we're open to that too.
I see Steve and Angela both have their hand raised. And Emily.
Hi, I'll go. This is Steve. And it was interestingly enough, during this moment here about 15 minutes ago, I got interrupted on the call because my executive director was calling me, so I needed to bail out for a minute to find out what was going on. And this is a conversation that's been happening at our place. I work at the OLCC. That's been observed by coworkers and it's been observed by management at this point. You know, we have a lot of people. We have a fair amount of people back to work in person. The majority of our people are still working remotely. And ever since we started that, which I guess kind of began in May when we reopened, there's been a really strong observation that people's social skills have gone down the tubes. It's like people's ability to interact with each other has taken a hit. And so we have a lot more coworkers, going after each other, coworkers going after management feeling like they're going after, seeming like they're going after workers in a way that we hadn't really seen before we all went off, into the COVID world. And it was almost like the way our discussions have been starting to happen at the OLCC, and even just this one I had with my executive director, is people have kind of forgotten how to get along. It's like it kind of was falling under the behavioral health in a way that we're not really engaging it here in a sense. But I just wanted to kind of bring that forward as something to be aware of. And I don't know if it's happening in other agencies and that people are seeing that themselves in the other areas where you all work. And I'm hoping it's not just the OLCC specific, but this idea that people were so isolated for so long that they kind of lost a little of their ability to get back into the swing of things of working side by side again and interacting with each other again. And I just want to throw that out as a potential idea of something that could be looked at, and I don't know what else to say about it. I'll stop there though.
Thank you, Steve. The thought that struck me when you shared that was, I wonder how many people are feeling a sense of conflict, not just with their work, but in other areas of their life. And it's a manifestation of just feeling stressed and anxious in general. not to dismiss the what you just shared about conflict in the workplace, but I'm wondering if that's just one piece of it, that people are just feeling anxious and kind of out of sorts as a whole.
I think that's true. I think that's true in the broader sense as well. Yes.
Yeah.
And I think that's a very interesting observation, because we usually bring our best selves to work. And to what Teresa just said, I've observed that for the last year and a half whenever I go out, which is pretty rarely, but even if it's to the local Costco or a grocery store, people not making eye contact, dressing down from what I remember them dressing, same kinds of people in same kinds of settings, people cutting in front of other people harshly, those kinds of things. And so it's probably not surprising that we're seeing some of that come into the workplace, but generally we think people bring their best selves to work, right? And if we're being influenced by just what's going on in the world around us, we really have a lot of opportunity, I think.
And I have some ideas, but I don't want to forget Angela and Emily as well.
Yeah, thanks, Brian. Just to add a thought to the current conversation, I think that's a great example of why this is something important for us to consider taking on, because we have to look at normalizing access to introductory kind of level mental health services, right? A lot of folks still stigmatize it, but they're not recognizing the world stressors that are impacting, social behavior and anxiety and, pandemic, all of those are weighing on folks, and they don't understand that what they're experiencing may be something that they could use some therapy or other mental health services to kind of work their way through. But my thought I wanted to add is, when we're talking about what we're hearing from other colleagues around this, one of the big areas I hear a lot about is struggles with navigating services and struggles with finding the right provider, not just from a culturally appropriate lens, but simply a personal comfort level lens, right? When we're looking at finding mental health providers, it's really tough to find the right one. So I would encourage that when we're looking at this, trying to look at ways to do like that, concierge service that was talked about, where it's not just the first connection, but that they're still there to make sure, hey, how'd that appointment go? Was that the right one, or do we need to look for a different one? Until somebody's fully engaged with a provider that's meeting their needs. And that's a data point I'd really love to know about is what does engagement look like over time, right? Not just that first appointment of engagement, but what's the duration, typical duration of engagement? How many folks do we lose after one or two appointments? Because I think that's going to be a really good indicator to help us understand how effective these are long-term, because we know none of these are magic wand processes, right? Mental health care takes time. And so anyone dropping off after those few appointments aren't truly engaged in those services. So those are my 2 cents. Thanks.
Well, thank you.
Really
This is helpful.
Yeah, that's a great idea for one of the activities of that work group would be to do that deeper dive into what the data says.
Emily?
Yeah, thank you. I echo a lot of what Steve and Angela said already. I would just add, not only are people in conflict more, but also there's increased racism. And so like the surge in anti-Asian hate, for example, where there's over 300% increase, within the last year of bias crimes and hate crimes being committed. And actually, Oregon has a bias hotline where it's language accessible in multiple languages. And so it'd be interesting to, learn about what their incidents are today, and then see if there's certain communities that need to be targeted based upon that data, and then other data, related data. And I know Brian is aware that we actually had a worker suicide recently at Oregon Department of Human Services among the child welfare area. And so I'm just curious. For sure, behavioral health. I agree that we should move or do something more. And I do know that, you know, in the bigger context, Oregon as a state has now invested in once in a generation investments in behavioral health. So that's a great thing. And Oregon Health Authority is, you know, trying to hire as many staff as they can. But, you know, we have like current state and then future state, and we're not there yet. We don't have the staff capacity to get to the future state yet. And so there's this painful state that we're currently in right now where people have all these needs and they're not getting met, and including people's ability to find, like Angela was saying, the right provider. And for sure, the mental health issues are heavily stigmatized in different communities. And I would say in some communities more than others, for like Asian and Latino, for example. And we have a lot of data that supports that. You know, our Oregon State, our Oregon Health Authority, the Oregon advocacy commissions, they've done a lot of research on that. And so if people haven't seen those reports, you know, I would recommend reviewing those. But yeah, in general, there's a shortage, I think, of mental health providers. And so back to this worker suicide, we're actually trying to figure out how to support the state workers that are colleagues of this person that committed suicide. And amongst our group at the union that's trying to figure out how to help, we have somebody who's had experience with the Umpqua Community College mass shooting incident that happened years ago. And she was talking about how she thought that they used a really great model where they invited people who were impacted by this incident, invited them to like a group experience that was about 3 to 4 hours long. And so folks could actually come to like a group session that was facilitated by someone, or they had the option of dropping in for like individual appointments that were like 20 or 30 minutes, but they were in the same workspace. So everyone was able to kind of see each other. There was like food and drink. There was like music. And so, you know, kind of help to relax people and help them to, you know, socialize again. But then they had an option of going to the group or individual to get some mental health support. And then after that, there was an option for referral out to more, you know, more specialized support if they needed it. But not everybody needed it. And so just wondering if there's room for doing a pilot, for example, something like that, like with child welfare workers, where it's a very high stress job, or even Oregon State Hospital workers, because I've just seen research recently that shows that Oregon State Hospital is one of the most dangerous places to work in the state. And so, you know, just we know that there's certain areas that are high stress work areas. And so, you know, we also have a recruitment and retention challenge for state government work. And so, you know, one thing that we've talked about is, wouldn't it be cool if we could say that, yes, it can be stressful work, but there are supports available, you know, and sort of move towards that, you know, what we've talked about at Pmac within the last year, kind of helping to educate people that EAP and Canopy isn't just for crisis situations, but, you know, just kind of going more upstream, getting people more used to talking about mental health, you know, destigmatizing that, you know, and just, yeah, so moving in that direction. So that's just one brainstorm idea. And for sure, like in my role with the People of Color Employee Resource Group and as the co-chair at OHA, and I've shared in the past PMAC meetings, but for sure our members are asking for anti-racist trauma-informed support. So just wanted to repeat that as well.
Thank you, Emily.
Yes.
And Stephen, it looks like Gayla has a comment as well.
Thank you. Yes, I just had a thought, and this is a really great conversation. Thanks, Emily. But I had a thought about, well, how do these services, I mean, that sounds great to have these different insurance companies provide this service for us, but how does this play out for people that live in rural areas and are off of the I-5 freeway? Because, you know, we've got lots of people that are around the state, and I know that several agencies do that. You know, Oregon Department of Human Services is not the only one that has groups around the state. And so I know that that's always a struggle, whether it's workers' comp or, you know, insurance related services. But, you know, I'm just kind of thinking about this behavioral health and how that maybe plays out for those folks. So thanks.
Yeah, thank you.
So far, oh, sorry, Stephen. I was just going to say, so far, I don't know if you're getting the same read I am, but based on the questions we asked, I think this is something that the group's interested in pursuing. I think this one is definitely kind of ripe for additional discussion. In terms of just all the ideas shared, I heard a lot of different things that we could talk to both the carriers and Canopy offline about, and to be able to come back to these groups with some additional information. I heard things about, you know, could we get more information from the medical carriers about how exactly are members supposed to figure out who the right behavioral health provider is for them? So, you know, can each medical carrier tell us exactly, practically speaking, how does a member go about doing that and working with the carrier to make that happen? I heard maybe working with Canopy to seeing under our contract whether there's anything they could do in the way of modifying or adding maybe some HR trainings to Steve's point, maybe about, you know, workplace conflict or adjusting to, you know, changes in the workplace. So there's a whole host of things I scribbled down based on your guys' comments that I think we'll be able to follow up on and bring something back to you guys relatively soon to react to.
Good. Well, that idea obviously prompted some discussion, and just what we wanted to hear. So the second idea that we'd like to offer.
I think one second, Gayla has her hand up again. Sorry, Stephen.
Oh, sure, please.
And I also wanted to make sure we saw that Angela and Kimberly have added to the chat here. Kimberly has said the Department of Corrections has staff suicides more than they want to admit. And Angela's suggestion was offering group sessions at high trauma work sites that are available on an ongoing drop-in basis. So go ahead, Gayla. Didn't want to interrupt you. I just want to make sure that
no problem. Thank you. Yeah, no, that's great. No, I just had something that I'm not sure if this is really the place to kind of bring this up, but at my agency, I deal with workers' comp, and so I'm seeing a lot of claims that come in that the person started with the standard, and so does this group, you know, because it's a PEP benefit also, right? The standard and having that long-term and short-term disability, because what we're seeing is that the person will go to the standard and they'll go through all of this stuff, telling their story, and then they're kicked out and told, no, your claim's denied because we see that there might be something related to work. And so then the person has to start a workers' compensation claim, and then they have to tell their story all over again, and, you know, to multiple people. And it just feels like there ought to be some way that, you know, we can make it better for our staff. And so
Gayla, let me recommend that maybe staff and Mercer set up a follow-up meeting with you directly to hear more about what you're observing, because this is something we can raise with standard, but I think we probably need a little more information from you.
Mm-hmm. Well, and I don't know if other agencies have that as well, because, but I've just definitely seen an uptick in that kind of action happening.
Well, this was part of our review of that Mercer conducted for us of our vendors, and I know that was a strong recommendation that came out, which was warm handoffs for folks who are going through, disability and off work, and getting them connected to other places. And so I definitely see an opportunity there, rather than the standard saying, oh, sorry, this is workman's comp, go here, but a little more connection and assistance for folks, so it doesn't feel like they're just kind of having to go through a maze to get those benefits.
Yeah, and even at a high level, I mean, we own the contract, so we need to make sure that they're providing adequate customer service. So I think this is something we want to follow up on anyways. So Gail, if you don't mind, I think maybe at some point next week, we'll reach out to you, someone will reach out to you and maybe set something up.
That'd be great. Yeah, no, that'd be great, because I mean, it makes people feel, and then there's this demand that they pay back to the standard, and they're like, what? I don't even have a claim filed, and you're wanting me to pay this back, and that's what I use to, to survive this during this time. So anyway, that'd be great. Thank you.
Did we have another person that wanted to make a comment, or are we?
I don't see any.
Okay. All right, well then let's transition to the next potential topic. So this idea came from Siobhan, chair of the board of PEB board, and that was, could we take a look at preventive screenings, and how can we encourage more people to get their preventive screenings that are age, gender, and medical history appropriate. So as background, just to take a look at what we're seeing in the claims data about compliance with preventive screenings, you can see 3 time periods: the calendar year 2019 in the blue bar, calendar year 20 in the green bar, and the last full year of 2021 in the purple bar, and then Mercer's book of business as a benchmark in the gray bar. So generally speaking, you can see that preventive screening rates went down in 2020 during the COVID year. No surprise there, right? We've heard all about that. People were staying away from hospitals and providers for a variety of reasons. But there seems to be a comeback, a little bit of a comeback, but still not to what the compliance levels were pre-pandemic. And for most of these screenings, you can see that compliance for the PEB population is lower than Mercer's book of business. So clearly an opportunity to support people in getting the right screenings at the right time. And that's a suggestion that Siobhan has. So similar set of ideas and questions. Is this something you're interested in pursuing? What do you see as other areas, other considerations here? What are you hearing from your colleagues? Is this varying by agency, location, job type? And then you can see some of the ideas to prompt some thinking about what we can do about it. Again, let's open it up to the floor and get your ideas.
I think Angela has her hand up.
Yeah, on the data on the previous slide, was that requests for these screenings or completed screenings based on the billing?
Completed screenings based upon claims data. So we know that these actually occurred.
And I say that because what I hear from others, and even my own personal experience, is that the providers are not available to complete these screenings. So all of my routine exams are well over 18 months out simply because of provider availability. I'm even on a wait list for my dental cleaning. And so I think that that's a huge factor here that may not be about member engagement as much as it's about provider availability. So while I think it's important to consider, I think that's very likely this is caused by a different problem entirely.
That's a very interesting observation. Are others having that experience or hearing about that among your colleagues or in your communities?
I had a similar experience with a specialty test, an annual test of the mammogram for women. My provider told me they were way backed up, and I just had to be assertive in making calls and demanding an appointment rather than them reaching out to me like they normally do to schedule an appointment.
So yeah, I guess this begs the question, is there a way, or could the carriers even tell us what sort of lags they're seeing in between requested, appointment times or test dates and when they actually can be made? And the second question, I think I probably answered it, but my guess is not all carriers have access to all that information equally, right? So the answer for Kaiser may be completely different than for Providence or Moda. So is there, Stephen, do you or any of your colleagues think, is there a way to get our arms around how much of the problem is a delay on the provider level?
Yeah, Brian, my thoughts are the same as yours, that likely Kaiser Permanente is able to track that because they have control of the whole system, and that's something that they build into their model, is to track preventive screenings. And they might have data on, when it's due and when people were contacted and when people took action and things like that. I doubt that the other carriers have that kind of information because they don't have the direct control of the actual providers, but we can ask. We'll see what data might be available. I doubt that it's not data.
Let's go to 2:30. We'll take a 5-minute break after that, and then I'll make up a little bit of time during, probably during the financial presentation, but we'll be able to make up a little bit of time afterwards. Angela?
Yeah, I was just going to suggest that maybe a data point we could ask for is turnover in terms of providers, right? How many have left the area as an available provider? How many total available providers per each of the specialties that provide this are available compared to previous years? Because I think maybe that could help us as well. Again, giving that dental example, I've been through 3 dentists and I'm currently waiting to be assigned one through Willamette Dental because of all the turnover they've had. And that's just in the past 2 years. So I think that may be an approach to learning about this.
So if you're asked, how can we better engage you in your dental services? You'd be like, well, be available. I mean,
right, exactly.
So what I'm hearing is before we start asking, members or member groups about, how we could engage them more, we need to determine whether there's even how much of an issue engagement really is compared to just what's happening in the marketplace.
Is it a capacity issue?
Yeah.
More than a desire and motivation issue on the part of the member.
So thinking out loud, just based on our discussions we've had up to this point today, it feels like we're definitely ready to roll on the behavioral health stuff, that Mercer and staff will definitely have quite a few takeaways, and that we could probably get going on that substantively pretty quickly. It feels like on the preventive services that we probably have some more information to gather and bring back to you to determine whether this will be a priority in the fall, or whether you guys think that engagement really is something you want to focus on. Does that sound about right to the group? Okay, I see a thumbs up. Okay. Okay, cool. And again, I definitely feel with the behavioral health stuff, when we debrief with Mercer and staff, we'll have plenty of action items and plenty of things to develop and bring back to you. Okay, so well, let me stop. Stephen, did you have another wrap-up slide, or was this the last? This is the last slide.
It.
Okay, well,
thank you.
Before we go on break, any other, comments or reactions about this shorter term work, or any other thoughts folks want to share? Okay. So let's,
quickly,
go ahead,
could.
Steve.
And I threw it in the chat. It was just that, as part of this whole delay in services, I think we have to, instead of just approaching them about the delays in services, I think we should ask them about, obviously all of our agencies suffered loss of employees. Now, obviously the healthcare industry certainly did. And I think we need to have that as a realistic conversation with the providers, saying, is that, how much of, how much staffing needs have you lost, and what are those staffing needs? Because that'll help us appreciate the delays as opposed to just complaining about the delays.
Yeah. Good point. Emily?
Yeah, I was just going to add, I don't know, to Steve's point earlier about folks, not having trouble getting along or socializing now. We did invite Dr. Daryl Wing Su to come in to speak to OHA and ODHS staff last week on microaggressions. And then he also shared micro interventions. So like how to address when slights happen in the workplace, unintentional, intentional, and then actually gave us a toolkit of for folks that are targets of those microaggressions, some ideas on how to respond, as well as people who are bystanders of the folks that are being microaggressed, and then also allies of those that are experiencing microaggressions. And so has like a whole toolkit of micro interventions that could be used. And so we thought that we would have like 150, 200 participants like we typically do for our other ERG events like that. But we ended up maxing out at 1,000 people.
Oh, wow.
Yeah, so over 1,000 state workers wanted that information and participated in that event last Wednesday.
So that
So
could be another area where maybe we just talk to Canopy about what's currently covered. And again, your recent recommendation is we're also looking at the Canopy renewal that will be effective next July. So these are exactly the sorts of things, timing wise, that we want to start talking to them about.
yeah, great. Thank you.
Cool. Okay, so with that, we will start our break and come back at about 2:36 in 5 minutes. And when we return, I believe we will be picking up, let me open up the agenda, the PEB 101 presentations, starting with a presentation on insurance concepts. So we will see you after the break.
Brian, can you see my slide? You're on mute if you're answering.
I said yes, and it's a very good looking slide, may I add.
So you see the presentation view and not the
I don't see the
It's got the notes.
No, I just see just the slide.
Okay.
And I can let you know if once you get going, if we see the notes, I'll let you know.
Okay.
It's a
It's
thing
of beauty.
Lovely.
Lovely.
Okay. So I think we can get started. So welcome back. We're just a few minutes past the agenda, but I am fairly confident we'll be able to make up some time. So starting off, this is the PEB 101 portion of the agenda. And again, this is where we just go over some basic information about PEB's business to give everyone kind of a baseline level of understanding about how we do what we do. As I mentioned earlier, when we get into Stephen's presentation a little later, we'll get into a lot more kind of dense data, just giving you a heads up. All that said, please ask questions as we roll along. So with that, Damien, I will turn it over to you. Thank you.
Thanks, Brian. Since I have 10 minutes and insurance concepts is a broad area, I chose to look at what makes up an insurance premium. That's what we're going to focus on today, specifically PEB. But to do that, we're going to take a look at 6 basic questions. And this really applies to any type of an insurance premium, not just specifically PEB. You have to take a look at who is being covered, what benefits are offered, are they rich, are they lean, how much healthcare is received, and that really is utilization, and what's the cost of each type of healthcare service that is received, what are the fixed costs, and are there value-added services that are offered as well. As we take a look at those 6 questions, this is just a graphic to really show who influences those factors in the case of PEB. You've got management, labor, legislature, regulators, PEB, insurance carriers. So all of those play in at different ports, at different pieces of time. Now to the first question, who is being covered? When you hear about an insurance pool for PEB, it's really, are there employees and dependents? Who's eligible of that pool for the benefits? Is it just full-time? Is it full-time and part-time? What is part-time? Are retirees included? Are early retirees included? What are the ages and the genders? That is really because if you have a much older population, the same as life insurance, typically as we age, we use more healthcare services rather than less. And genders is important for, especially for women of childbearing age. How big are the families? How healthy is everyone that's in the pool? All those are things to consider. In taking a look at PEB, this is some pretty recent data about who's being covered. And you can see the breakdown in the pie chart between Providence, Moda, and Kaiser. The lower left portion in purple and gold, you see the breakdown of employees and dependents. There is a difference. You can see Kaiser has 42% employees, whereas Providence is the low at only 39%. But these aren't huge differences, any of these. On the right-hand side, you see the male-female makeup, and those are even closer. So there's not a huge difference there. Now, when we take a look at what benefits are being offered, what I wanted to do is briefly take you back in time a little bit to 2014 with the Affordable Care Act, which many called Obamacare at that time. And that's really when they introduced some language about metal tiers as a shorthand way to talk about how much are you paying as an individual versus how much your insurer is paying, by and large, for your care. This is not every specific type of care you get, but overall, you can see that a bronze plan, it's a 60-40 split where you're paying a lot more. But if you're extremely healthy, low utilizer, that may be a good option for you. Whereas Platinum, you're paying only about 10% of the plan and the insurance pays the other 90%. I do this to show you how rich PEB's benefits are. They're rich with a capital R. In the small group market, 14% of the plans are what are called platinum level. That's the 90-10 split. In OEB, it's 20% of the plans. In PEB, it is all the plans. And in fact, some of the PEB plans are richer than 90-10. They're more like a 95-5 split. Just shows you that we really have some very good benefits. Now, this is a graphic that tries to take a lot of the different things that I mentioned on the first couple of slides that go into making up an insurance premium. And you can see the insurance cost is going to go up as you go from left to right. In the middle, you have to take a look again at what is the age and the gender of whoever's making up the population, what's the cost per service, and how many services are they utilizing. Then you've got the overall health of the population. If you've got a population that is older and sicker than normal, they're going to cost more than normal, and the insurer is going to want to cover that cost. Chronic conditions are another really big indicator. And within that, I'd like to differentiate between a chronic condition that is under good maintenance care. The patient is doing what the providers want them to do in terms of all of the care they need to keep that chronic condition under control. Insurance carriers like that. What's really tough for them to get a handle on are chronic conditions when the patient is not coming in and is not following protocols. So all of these go together to really take a look at insurance costs. Now, this is a slide that I think is really telling of healthcare in the United States. If you take a look at the boxes, 1% of the population, this is across the United States, 1% of the population accounts for almost 25% of the total healthcare spend. 5% of the population accounts for more than half of the cost. So that means a lot of people are out there who are receiving their services and not really contributing to the overall spend. This is really indicative of how we really go after catastrophic cases. And if you take a look at socialized medicine in other countries, they don't have that skew because they focus on primary care and prevention, but it's the heroic care that is very hard to get there. But you can see how skewed the spending is across the United States. And if you were to take a look at Oregon, it would be the same phenomenon. PEB, it would be the same phenomenon. A very few or a very small number of people account for the majority of the cost. Now, also in the top, the costs of each type of healthcare, it was brought up earlier in the meeting, regional variation. The best example of that I could get, because the prices have to be approved by DCBS and then they're published. This is in the small group market, which are groups of 50 or fewer employees. Actually, excuse me, this is the individual market. But you take a look at the DCBS has a standard gold plan, which is identical benefits for these carriers. So the only difference, since they're covering exactly the same amount, is what is the regional cost variation. And that's driven by providers, lack of specialists, and also lack of competition. If there's only one hospital in a geographic area, they've got no competition to have them keep their costs down or under control. So you can see this is the price variation between the high and the low county. So Pacific Source, for example, in the middle, their difference between their lowest cost county and their highest cost county for the exact same benefits in the exact same plan is about a 16% difference. And I know those of you that are from rural areas don't find that surprising at all. The next thing I wanted to mention was fixed costs. And you can see there's very little in PEB in terms of admin, taxes and fees, and carrier costs. The vast majority, 91% of it, is claims costs. And the reason I show this is we could peck away at trying to lower carrier costs a little bit or admin fees a little bit. But where we're really going to get a bang for our buck of focus is focusing on the claims and how can we reduce claims costs. The last one we wanted to ask or talk about in those 6 questions was value-added services. We've been talking a lot, the first part of the meeting, about wellness and well-being programs. PEB also has bulk pharmacy purchasing, and that drives lower costs. I mean, none of us think of pharmaceutical prices as lower, but they could be worse. PEB is doing a very good job, and our carriers are doing an excellent job in trying to manage the pharmacy costs and keep them down. We've got health policy experts and expert advisors on the board and on work groups such as this. And from Mercer is a really good example as our consultant, bringing that expertise to the group. And the 2 that are highlighted below are fairly recent, and that's the healthcare cost increases are capped at 3.4%, excluding taxes and fees. That is mandated for us. That's going to be a particular challenge as we move forward with the bounce back of care that we've been talking about from COVID and the supplier costs going up because they might not be able to keep the proper staff that they need. We also have payments capped to a good number of hospitals in the state. Those are capped at 200% of Medicare, excuse me. Okay, last really real point I wanted to make is that PEB is a huge group of employees, much bigger than a lot of commercial clients are. And bigger is better in this case. Because we have such a large pool of people, there's greater rate stability over time. You could have a half dozen employees with a $10 million claim, and it's really not going to move the needle because you've got so many people that have very, very low utilization to balance that out. That's the first and second point. You're spreading the fixed cost across a lot more individuals, so the per member per month cost is even lower. We have purchasing power. PEB and OEB go to these carriers, and we, any large customer gets any commercial. I'm sorry, I kind of a brain fade there. Anytime you are a large customer, you can usually get some large discounts, whatever you're buying, whether it's healthcare or widgets. Large customers speak because no commercial company wants to lose their largest customer or customers. We can drive medical care changes because we have a significant pool within the state. And we can also drive policy change. Reference pricing is a good example of that. So I've thrown a lot of stuff at you. Under 10, not quite. Now I'll take any thoughts or questions.
Thank you, Damien. Any questions from the audience? Awesome. Thank you, Damien. Next up, we have Dr. Nelner again, who's going to talk about and present information related to member health characteristics. But I did see really quick that Emily just raised her hand. So Emily?
Yeah, sorry, I'm so slow. I was just gonna thank him for the presentation, and also I'm a member of SEIU's Universal Health Coverage Committee. I'm just wondering if I might be able to follow up with him later for like a question.
Damien, we can certainly do that, Emily. We can set something up. And Damien, would you prefer to go through me, or do you just want Emily to email you directly?
Yeah, we're just putting together a white paper
right now. My internet all
now.
of a sudden is not very stable, and I couldn't hear any of that if there was a question. I'm sorry.
It's all right, Damien.
Damien, I was just thanking you for your presentation and just mentioning I'm part of the Universal Health Coverage Committee for SEIU, and we're putting together a white paper right now, and I'm just wondering if it would be all right if I reached out to you. I could do it through Brian. With a question. Just trying to get universal health coverage ultimately for our Oregonians.
Yeah, and so go ahead and follow up with me, Emily. I'm not sure if Damien's having some bandwidth issues right now. So
sounds good.
I am back. It totally kicked me out, but I'm back. I'll try it now. Emily, what was your question?
can Emily reach out to you about some other work she's doing related to this?
Of course.
Yeah.
All right.
Thank you. Yeah, I'm just on
bet.
this Universal Health Coverage Committee and we're doing a white paper and I would love to talk to you more.
Sure. I'd be more
Thanks.
than happy to.
All right, Kelly?
Hey, just really quick, I really appreciated that overview. And one of the questions I have is some feedback we're getting from participants in the benefits workshops we do is just that kind of basic overview you did of the language of what is a premium, what's in network, what's out of network. And so one of the things Uplift has been talking about is maybe coming up with that kind of overview. And I wondered, one, does it exist somewhere else already? Or two, would that be useful? And maybe people can just send notes offline to us.
Okay. We can do that. Other questions before we hand it back to Stephen? Okay. So Stephen, I still think looking at the agenda, we're scheduled to adjourn at 3:45. I think we can still take a good 40 minutes for this presentation, especially if we have questions. And again, for the audience, some of the stuff will be a little denser in terms of data, but if you have questions, please just ask away. This sort of stuff helps us, figure out priorities or what's an outlier that we may need to address, et cetera. So with that said, Dr. Nelner, I'll turn it over to you.
Thank you, Brian. And thank you, Damien. That was a great lead in to this conversation. You gave the broad framework of how insurance works, and now we're going to get into some of the details that will put the flesh on the framework that you gave. But I'll just reiterate that because there's a lot of data on these slides, I'm just going to point out to you high-level observations and trends that you might want to take away from a given slide. Most of the numbers I'm going to leave for you as reference. You have this information so you can look at that. But again, if you have any specific questions, we can certainly drill down on anything that's of interest to you. So Damien already had a slide that showed the distribution of current membership. You can see we've broken that down by the last 3 years from 2020 to 2021 and 2022. So you can see that the majority of your members are in the Providence and statewide plans. But again, I'm not going to spend a lot of time on the details below. Next slide, please. And then what is the composition of the subscriber model? So employee only, employee and spouse, employer and child, or family. And takeaways here are that for the most part, you have some relative stability there in 2022. That's the bar to the left in the light blue. You have slightly fewer employee only. Employee and spouse is pretty stable. Employee and child is pretty stable, but a slight increase in the family coverage. And you can see on the bottom, just the bolded numbers in the very bottom, that the population, the total population, has stayed pretty much the same, went up a little bit from 2020 and 2021, and then came down a little bit in 22, but still pretty stable. Next slide, please. Damien already showed a slide about gender distribution, so we won't spend a lot of time on this one. We can go to the next slide, please. And this breaks down by age, so might be a bit of interest here to see that, just for the sake of orientation, the green bar on the right is employees who are 50 years and older, and all of you who are still under 50 are considered youngsters. You're in the blue bar. And you can see that the youngest population is in the MOTIV program and Kaiser deductible, and the oldest part of your population is pretty much in statewide. And so again, just some general directional information there. Next slide, please. This is a slide that shows what percentage of your population participated in the HEM. And you can see that in 2020, about 12% of the population was not participating. So very large participation, 88% and 90% in 2021, a bit of a drop off in 2022. And I don't think I have any explanation for that, but an observation at least. Next slide, please. So this looks at university employees versus non-university employees and what plans they're choosing. And you can see that there's a difference, that the university employees are in the green bar, non-university employees in the blue bar. Seems that university employees select Providence and statewide slightly more than they do non-university employees. And non-university employees tend to choose Kaiser HMO and Kaiser Deductible and MODA at a slightly higher rate. Next slide, please. So that was more demographics, lay of the land. Now we're going to get into some of the data. And again, as Brian said, and I'm going to repeat, we're going to try to keep it light on the actual numbers and the deep dive, but look at general trends. But just to give you some idea of what we're looking at, we're going to be looking at complete calendar years. 2 years prior is going to be pre-COVID 2019, which will be very useful for comparison. Then the peak of the COVID era in calendar year 2020 is what we consider 1 year prior. And the current period is the last full year of data that we have from 2021. You can see that where the different plans fall in the structure here. And a note on the bottom that the Kaiser utilization reporting excludes approximately $24 million in integrated care fees for the current period. And you can see a similar, slightly less amount for 1 year prior and 2 years prior. And next slide, please. We're going to now look at some of the costs in the aggregate. So we're first going to look at your self-insured population, then we'll look at insured, and then we'll look at all of them combined. And just again, we're looking primarily at changes over the course of time. So 2 years ago, pre-COVID, you can see that there was a gross medical spend of around $706 million for your self-insured funds. That went down by 7.3% in 2020. And again, a lot of that was putting off care because of the COVID era and lack of access to providers and facilities. Current year, we're seeing a bit of a rebound, but still not to the pre-pandemic levels. So a 4.7% increase from 2020.
And Stephen, I think this is where I would just like to ask, and it's kind of a loaded question, but because care was deferred during the pandemic, there's a chance that eventually when it bounces back a little higher than before, right? Because for some folks who put off care, that may actually result in more costly care later on. So is that correct too?
That's the way we're thinking of it as well. You're right that that it's likely to rebound higher than it was before, just on a pure utilization basis. And that's not even counting increased cost of care, but unit price and things like that, and inflationary costs of medications and things like that. But yes, just that deferred care. You're probably hearing in the national public press that we're seeing physicians are seeing that people who delayed their preventive screenings are now coming in, and instead of catching it early at stage 1 cancer, for example, they're now stage 3 or 4. So much more critical cases, much more costly to manage. So very likely that we're going to see more of that in the coming years. And since we're still in the pandemic to some degree, we don't really know when that inflection point will level off, but it could go for a number of years.
So we expect this to probably be a conversation point for the near future for a while.
Right. Now, the one mitigating circumstance you can see in the footnote there that kept your costs a bit lower in the last year and 2020 and 2021 was the SB 1067 legislation that mandated that costs around maternity, particularly deliveries and newborns, was capped. And you heard Damien mention it earlier that it was capped at the lowest of the allowed rates or 200% of Medicare. So that did make an impact in a positive way for your overall healthcare cost spend. And there's some rebating from drug costs in medical that have offset some of these costs, but that's the minutia. I think the big picture trend is what we're most interested in here. Let's move to the next slide, which looks at our fully insured members. So that's a smaller part of the spend, but somewhat of a similar pattern. 2 years ago, pre-pandemic, about $150 million. That went down by almost 10% in 2020. And we not only saw a recovery, but to some degree, Brian, what you were describing is it's gone even higher than it was in the previous year and almost 20% higher than it was in 2020. And you can see the breakdown of how that spend was distributed between medical and prescription drug. Prescription drug continued to go up even in that pandemic year by 3.7% in 2020, but was offset by a reduction in medical spend. But that again rebounded in 2021 for medical pretty dramatically. Next slide shows the roll-up of fully insured and self-insured. So now your total spend 2 years ago was about $850 million. Went down about 8% in 2020 to $787 million, and has come up again in 2021, but not quite to the pre-pandemic level of 2019, but nonetheless a 7.1% increase in the aggregate from 2020 to 2021. Again, driven medical prescription drug costs were higher even in that pandemic year of 2020, and again an increase in 2021, driving the overall increase in costs for both years, for 2021, I should say, over 2020. And a note on the bottom, and Damien mentioned this earlier, that you have a cap, a mandated cap of 3.4% maximum cost increase each year that you can see is being challenged by what you're actually seeing in your experience. Next slide, please. So this slide is just looking at the annualized cost increases. This is for looking at a 5-year period in time. And the purple line on the top, the straight bar, is the line of best fit, if you will, that takes into account the fluctuation around it, but it's the average cost increase year over year. But if you look at the squiggly line for choice and statewide, you can see the dip below the average cost trend in 2020 in that pandemic year. And then you can see a gradual increase and even a spike toward the end of last year in costs. Overall, over that course of time, Providence medical went up about just less than 1%, and RX almost 11.5%. Statewide went down in medical slightly and up in prescription drug costs. Next slide, please. And again, if you have any comments or questions, want to drill down on anything, please don't hesitate to raise your hand or interrupt. Looking at the same kind of graph for Kaiser and Moda for over 5 years, similar dip in costs and expenses in 2020. Kaiser overall for 5 years, medical down by 2.4%, medication costs up by 2%. Moda, just a slight increase in medical costs over that period of time, but 6.5% increase in prescription drug costs. One thing that we should note on the footnote there, and this is a theme that we'll talk a little bit more about when we talk about risk scoring, health risk scores. I'll just mention now what health risk scores are. Risk scores are a methodology that are used to try to look at the health risk of the population, and it's derived from claims costs. So what people are actually going to get services for. Kaiser has noted that their risk scores might be a little bit underreported because some of their care is coming through virtual care, and they've encouraged that to be more efficient. And that could impact the other carriers too that do have virtual service as well, but I think it might have impacted Kaiser a bit more. And the other thing about risk scoring that was impacted by the that 2020 pandemic era was that if you're not going to get costs, if you're not going to get care, then you're not incurring any claims, right? But that doesn't necessarily mean you still don't have a condition. I might have diabetes and I'm not going regular to my provider, or I might be delaying other preventive screenings. So those claims aren't being incurred, and therefore they're not adding to the risk score. So risk scoring is probably underrepresented in 2020 relative to what it probably was if it was to truly represent the health status of the population. So maybe more detail than you needed to or wanted to know at this point, but just a quick primer on risk scoring. All right, we can move to the next slide, please. So now we're going to dive in a little bit to some of the components of that trend. So we talked about the overall increase. This is now aggregate numbers across all of your health plans and all of your spend. So you can see that we're comparing prior year, which was 2020. That's again the pandemic year. The current year is 2021 in the blue on the right, generally on the right. But you can see that the total spend in 2020 is down, as we've been discussing. What contributed to that? So utilization, almost 10% lower utilization, contributed to that in 2020. But in 2021, utilization increased by almost 10%. Unit costs also went down in 2020 and went up by 6.5% in 2021. So those are the components that are contributing to the difference between 20 and 2021. And then I just gave the primer on member health risk. Some of this might be deflated by the fact that people aren't showing up in claims, even if they have some health risk or health status that couldn't be recognized until they actually had a procedure or went to a physician. So while member health risk went down by virtue of risk scoring based upon claims, there was probably more risk there, and this increase last year was probably not completely due just to newly identified risk. It might be just bouncing back to identify risk that might have already been there. Next slide, please. This is a little bit more deeper dive. I would just focus more on that first column. This is a breakdown by the different plans. Or the second column, largest component of change for Providence, it was increase in prescription specialty drugs. Statewide, it was more outpatient surgery. MODA was prescription specialty drugs. Kaiser deductible was mental health, and Kaiser HMO was also mental health. That drove higher costs in 2021. Next slide, please. So pharmacy, you saw in previous slides that pharmacy continued to go up even in the pandemic era and almost unabated and continues. And we see this theme with all of our Mercer clients. Costs for prescription drugs keeps going up. Non-specialty drugs go up, but in particular, specialty drugs go up even more. And you can see that in the graph to the left. Total drug spend was about a 4.1% increase from 20 to 21. And specialty drugs, non-specialty only accounted for about 2.6% of that cost, but specialty drugs really drove it with their increase in cost. The other thing to note on the right in the pie chart is that not only did specialty drugs have the highest unit cost increase, but also 43% of all of the drugs that were prescribed were in that category. So now you've got increased cost and increased number of units that were used. So that really contributed to the cost increase from 2020 to 2021. And on the bottom, you can see some of the specific drugs there, but I'll leave that more for your reference unless anybody has any questions there. If not, we can move forward to the next slide. So now we're going to talk a little bit more about that risk, and I already gave you the preview into what a risk score is. So unless somebody has more questions about that, I'll just go with what the description we've given so far. And on the bottom, we've got another footnote. The risk scores are that relative cost of a member determined by their underlying illness burden. based upon their age, sex, and diagnosis data. So it's a combination of claims, but it's also a combination of age and some other demographics. We normalize those to give we're going to use an average reading on some of the other slides that will give you some sense of how people fluctuate around a particular score. That normalized score for an average risk is 1. And you can see that in this slide. So anything that's above a 1 would be higher than the average risk scoring, and anything below 1, of course, would be lower. So you can see the Kaiser deductible plan had the lowest risk scoring of all, the healthiest population, if you will. And then you can see the different distribution. The only other one that was lower was Providence in 2020. Other than that, the populations were either at or above the average risk.
And then Stephen, just a point of clarification. So while we don't want risk to increase overall across PEB, risk increases within a specific plan may be okay. So for example, in the case of Providence Choice, that by itself, the risk score increasing within that plan isn't necessarily a bad thing if that means members who are at higher risk are enrolling in Providence at a greater rate, right, in a more managed plan. Is that fair to say?
Yes, that's fair to say.
There's a lot of nuances to this information.
That's very true. Yeah. You can dissect it in many different ways. So, but it's very true. And the other thing is that people make choices about which plan they'll enroll in, and dependent also upon the amount of care they think they'll need and other factors that they consider. So some of that's driven by personal preference, personal need, and as you say, also efficiency of the model as well. So a variety of factors can influence these things. And yes, it's not necessarily a good or bad thing. It's just what it is. And I made note of this earlier. You can see the second bullet point in the footnote is that shifting of services to non-claims-based interactions may be lowering risk scores. So that's the comment I made previously about Kaiser in particular, but others as well. If there were virtual services and virtual appointments that weren't charged, and that's particularly the case in Kaiser, that doesn't necessarily charge for a virtual or chat session in between scheduled visits, that wouldn't show up in the claims data, and that would underestimate risk scoring because it wasn't another claim. Right, next slide, please. So this is, and again, Damien did a nice job of giving some sense of this early on. This is a little bit more detail on that migration. So where did people go? Where were they before and where did they go? Again, a lot of numbers on this page. I think the big story is that you can see the biggest change in shifting among plans was Providence and statewide on the net from last year to the current year. This is January 21, and people who are enrolled in plans this year. There was a net decrease in Providence and statewide, and some of those people may have shifted to MODA, as you can see. And in the net, there was a slight decrease in Kaiser HMO and just a slight increase in Kaiser deductible. And then some of this is influenced by shifting just between plans for people who were in plans previously, but then you can see there's some people who are new to PEB and they had to make a selection. You can see in the second column from the right where the new people to PEB, newly eligible plan members, chose to go. So again, I made reference earlier to a normalization. This is a risk-adjusted cost. The purple line is risk-adjusted cost. So again, it's taking into account what the illness burden is within that particular population. And I noticed that when I looked at these slides just before the call, that something happened in translation, that the Kaiser deductible, that first column, ended up not hitting where it should have. The bar graph should be up to 552, so it would hit just about at that dotted line, which is consistent with the comment that only Providence Plan had a lower cost relative to average risk. So again, just more informational. Now, this I thought was interesting, and you probably will find this interesting too. This is the relative expense cost for similar services, how it varies across the state. And you can see in the dark salmon color, it's 15% or more higher than the average cost, down to the green, which is 5% or more lower than the average cost. And in the inserted blue box, you can see that the eastern region counties are about 26% more costly than the PEB average, while the central region counties are about 8% lower, and then a few counties that are 4% lower, and Northwest, Southwest, and Metro are about 1 to 3% lower than the overall average. So not only is it hard to access care in some of these places, but it's also more costly. And we talked about that earlier about competition probably driving up costs or leaving costs higher than in areas where there's more competition and more access. Next slide, please. Clinical conditions and utilization trends. So another very, very detailed slide. I'm going to focus primarily on the colors. So I'm looking at the upper left-hand graph, and you can see that there are 4 red boxes or pink boxes, and those are indicating conditions that increased from 2019 to 2020 to 2021. And you can see that anxiety claims increased, depression claims increased, diabetes claims increased, and low back disorder increased. Now, all of these are areas that we've talked about before. You probably recall from discussions earlier in the year, we've talked about them in the context of some of the areas we can target with supporting people and finding resources. We will certainly be talking about these again as we move into that well-being strategy discussion that we had earlier, that we'd set up earlier. This will serve as guiding ideas for what PEB should be focused on in supporting members with. So those are really key areas. On the bottom, you can see that the rankings changed a little bit, and diabetes moved from number 2 to number 1 from 2020 to 2021. Osteoarthritis also moved up. So those are important areas, and those mental health issues are also very important to keep on our radar, as we've all been discussing. Next slide, please. So here's the complete ranking of different areas, and we've added in some green boxes to show where some areas decreased. Now, I'll add again that note that SB 1067 influenced pregnancy to move down from where it was previously, moved down slightly from ranking of 2nd in the previous 2 years. What capping of costs for a pregnancy caused that to move down a bit. But osteoarthritis up, and you can see respiratory infections moved up to number 5. Again, that is likely the number of people, the increased number of people that were being treated for COVID in hospitals and in outpatient settings. So that would be considered under respiratory infections, and that probably accounts for why it moved from 30th in 2019 to 15th in 20, and still showing up as even higher, ranked 5th in 2021. Joint disorders moving up, Crohn's. So we've already looked at, that's okay, you can move to that one. This is more for a reference slide, and we've already looked at this in the previous discussion. So a reiteration of the preventive screening rates, but we had some interesting observations when we had the discussion. It may not just be people's lack of willingness to get the screenings, it may be capacity of the providers to actually provide them. So we will take a look at that. Emily, I see your comment there. You ask, could wildfires and particulates in the atmosphere contribute to respiratory? And they certainly could. That's a very good observation.
Thanks.
You're welcome. So telemedicine, this is probably not surprising. You can see that there was a spike in telemedicine, certainly in a trend upward in telemedicine visits compared to community providers in Kaiser's, and this is Kaiser Deductible and Kaiser HMO. And we mentioned this earlier, that they offered a robust capability to have virtual interactions between physical visits. And you can see how that played out over the course of time. And we're talking about.
Stephen, have we gotten any sense whether there's additional capacity there to continue increasing telemedicine, especially like in rural areas or for members who just may have transportation issues? Or does this leveling off reflect that the capacity isn't quite there in the market?
It's a good question. I think we can follow up with the carriers to ask that question. I think that's a good takeaway. And by the way, I should have made clear that this is telemedicine visits relative to MHSA, stands for mental health and substance abuse. So that the blue bar on the bottom is mental health, substance abuse, and everything above it is regular medical. So a lot of utilization for mental health, substance abuse, which is very encouraging, as we know, because of that access question. And we can see that people are availing themselves of that service.
Yeah, and from a policy standpoint, just looking at this, and I don't know the answer, but my question is, should we be looking to increase telemedicine visits, or is there not the avenue or capacity to increase at this time?
Yeah, and the one idea I'll say, this regardless of what the carriers are offering and can offer in those areas, I'll just say that in the marketplace, what we're seeing among Mercer clients of all kinds is that there's a substantial interest in supplementing what the medical plans offer and the EAP offers. That there's some gaps in between with access, quality to care. And we are seeing that telemedicine, virtual care is filling that gap with some specialty vendors in that space. So beyond, one question is, what do the carriers have in terms of additional capacity? And then a second question that could surround that as well is, should we look also at supplemental care to our medical plans and our EAP to fill in the gaps?
Agreed. Thank you.
Yeah. All right, next slide, please. And this is breaking it down for the other carriers, Motor, Providence, and statewide, and you can see it's on a visits per 1,000. Similar convention for colors, mental health, substance abuse in blue, and mental health, substance abuse are in green. You can see that most of the care for these carriers was in that mental health, substance abuse for telemedicine, not as much for the non-mental health. Emergency room visits. So what happened there? So this can be a bit of a mixed picture, because we know that people who had COVID symptoms were going to emergency rooms. People that didn't have COVID and had other needs were staying away from emergency rooms. So in some sense, some of those dynamics balanced out. Nonetheless, you can see that there was generally a dip in the early COVID era of March and April of 2020, but then moved up a bit in time, and a general trend upward throughout the next year or so after 2020. And 9% increase over the whole time. So the final slide is just a summary. And by the way, these and a few additional slides, which are in the appendix, were presented to the PEB board recently. So you're seeing the same thing as the PEB board did. And this was a roll up and a summary of what the opportunities for PEB are. So mental health, increase the prevalent, there's an increasing prevalence of depression and anxiety. We saw that in the claims data. We saw that in the utilization for telehealth support. Recommendations are evaluate the adequacy of the access to mental health, just the same things we're talking about today. Investigate whether online behavioral self-services can supplement the current networks. That's what I just mentioned. Encourage the use of screenings, referrals for mental health. So in other words, in other services, I'm going to pick out some of the things like diabetes prevention service, for example. That's a new service that's being made available through some of the carriers. Oftentimes those vendors will screen for anxiety and depression and help triage and refer members that have those comorbid conditions along with diabetes or other chronic conditions to get support for their behavioral health needs. So are we trying to turn over all of the stones to identify when people really need help? And then assess it.
And Stephen, Angela asked in the comments, do we know if the change in telehealth is by choice of the patient or the provider, or whether it's the provider no longer making it the primary offering or even offered at all? And again, I think these are all things we can probably follow up with, but they're good questions.
They're very good questions. And I don't know that there's a single answer because every provider, in my own case, I've got a physician appointment I wanted to make virtually, and the physician's office said, no, for the annual, you've got to come in for that. In between, you can do virtual. So I think and that wasn't the same case just a few months ago. So I have a feeling that's what's occurring, that dynamic is shifting and evolving, and providers, individual providers, as well as groups of providers and facilities are all figuring that out right now. So it's probably not going to be easy to get a singular answer to that, but we certainly will see what we can find from feedback from the various carriers and providers.
Perfect, thank you.
Diabetes, number 2. So your diabetes is your top spend category overall, and the prevalence is increasing. And the view on society as a whole is that more and more people are going to be developing type 2 diabetes because we're more sedentary, we're aging, we are eating less well and exercising less. So all those factors are contributing to the development of chronic diabetes and type 2 diabetes. So big opportunity. So let's do what we can to attack it and address those risk factors upstream with diabetes prevention programs. That's what DPP stands for, and wellness, general wellness programs. And this came out before the Inflation Reduction Act was just approved in recent days, and one of the provisions of that act was to lower the cost of insulin. So that would also apply here for Medicare and non-Medicare populations. So really, that's something that hopefully legislation will help us address as well as the market buying power that Damien was referring to earlier for organizations as large as PEP. Musculoskeletal and back disorders, you saw those increasing, the prevalence of those increasing in recent years. And we know that there's a big spend, $34 million on those categories alone. So are there opportunities to develop centers of excellence so that we can direct people to the highest quality of care, the most efficient care? Efficiency means high quality and low cost, the intersection of those two. And could we develop a plan to incent people to go to those centers of excellence to get that care in the most efficient way? Evaluate the carrier's prevention strategies and integrate digital MSK solutions. MSK is musculoskeletal. That's another area where we know that there are point solutions or niche vendors, we call them sometimes, that are filling the gap between traditional medical care and I'll just say traditional medical care. And some of those solutions are virtual. We say digital here, but they can also be a combination of an app, but they can also be a video conference, and it can be literally physical therapy delivered remotely. Some vendors do it with sensors that are placed on the body so that the physical therapist can monitor that you're doing the exercise correctly. Others are self-guided, but a combination of those. And again, it's an attempt to try to intervene early on before people go to surgery that might not be necessary, or high-cost imaging studies that also may not be necessary if we can resolve it with good physical therapy, exercise, and prevention. And finally, that last point, that's music to our ears who are concerned about health and well-being and wellness. All the things that we focus on in our traditional wellness initiatives are helping people manage their weight, manage their stress, be resilient, eat well, move more. All those kinds of things are really opportunities at the very core of preventing back issues and joint issues. Specialty drugs. You saw we kept ringing the bell on that one throughout the presentation, that specialty drug costs continue to escalate year after year, and they're the largest percentage of prescriptions that are being filled. So can we find ways to identify where people are going and get them to some of these specialty medications? For example, you have to go to an infusion center or have to go to an outpatient facility. They're not medications that you can just take at home, but sometimes people are prescribed those when they didn't really need those settings. So can we look at where people are, what medications people are using, assess whether or not they're appropriate and in the appropriate setting, and steer people to a lower cost option that's just as efficacious, just as likely to result in good outcomes. And again, do all we can to monitor the PBM is the pharmacy benefit manager that manages the drugs in the formulary. And finally, last but not least, probably last and the most important, is manage to that 3.4% mandate, given all the pressures that are on the healthcare system with lack of capacity, lack of competition, and inflationary costs in general. It's going to be a challenge. So take a good look at the vendors who are there, make sure that we're getting the best possible rates that we can, and steering people to the service providers who are the most efficient. I mentioned that earlier in the context of COEs, Centers of Excellence, but it's also just generally true for primary care and specialty care outside of the need to go for surgery. Are we getting people to providers who really are going to give the best outcomes at the lowest cost? So that was a lot to run through in a few minutes, but I'm going to pause and see if you have any comments or questions about anything throughout that presentation.
Okay, and I'm looking at the chat. I think we're good.
Kelly, thank you. Good comment. That was a Indy 500 version of
yes.
getting through this.
Thank you very much, Dr. Nelner. So we have 2 more presentations, and I'm pretty sure we'll still be able to get you out and adjourn the meeting on time. I'm going to cover at a high level a description of our budget and finance, and then Cindy Bowman is going to provide some high level information on what we're planning for open enrollment. And for Pmac folks, you've already heard the open enrollment presentation during the last meeting. So I am going to share the next presentation. Okay, so this is the financial and budget overview. As I mentioned, I'm going to do the presentation. I'll be doing it on behalf of our director, Ali Hassoun, who's also our resident expert when it comes to budget and finance. So starting off on this slide 2, this shows our operating fund and stabilization fund. So PEB's budget, like other state agencies, is built on a biennial basis with a state fiscal year that runs July 1 to June 30. But the PEB plans run on a calendar year basis. So our budget biennium actually includes at least portions of 3 different plan years, which makes the whole kind of budget thing a little complicated. So to bridge this gap, I'll go on to the next slide. The legislature created 2 different mandated budget tests that PEB must follow. I'm actually not going to spend time reading the actual statutory language, because frankly, I think it's more confusing than helpful. And the later slides explain exactly what they are. But in a long story short, the first test measures outflows or total expenditures. And then the second test actually measures the premium inflows from agencies that we then pass on to the carriers for core benefits. So I'm actually going to start by explaining the premium cap. So again, the rule is that we have to keep our expenses under 3.4% annually. And so for this premium budget test, it measures the amount of benefit premiums for core benefits that we receive from agencies, and then again, pass through to our benefit carriers each year. It's really about those inflows from the agencies. And the board is kind of the group that actually manages this because they make the rate and the benefit decisions on an annual basis. And so, you know, their goal is to try to keep each contract increase limited to 3.5 or 3.4% annually, as well as the overall core benefit spend under 3.4%. So let me stop there. Are there any questions? If there are, please speak up, because I realize I cannot see the chat at this point. So please just interrupt me if you have questions. Okay, so this next slide looks at expenditures or outflows. So again, this is set by the legislature, but this includes other operating costs not included or factored into the premium test. So this includes costs outside of core benefit premiums. So this would include optional benefits, as well as stuff like costs for our IT system. And at a high level, PEB is mandated to keep our total operating costs or outflows limited to 3.4% a biennium. But again, we try to manage these things annually. Okay. So this slide just shows the composite rate year over year from the past 10 years. And again, the composite rate is made up of the core benefit premiums and is really about those portion of the premiums we receive from agencies and then pass on to the carriers for those benefits. Okay, then the last slide is just a note that we've touched on these issues already today, but there's just a lot of budgetary concerns going forward. We talked about care deferral. So the fact that a lot of people put off care either intentionally or unintentionally during the pandemic, and that will kind of come back to us at some point in the future. Inflationary pressures as well. So frankly, the care that maybe should have been received last year is going to cost more if it's provided next year because of inflation. As well as just trying to continue to manage the declining member health risk that Stephen presented information about. And last, we just included some information about the health engagement model incentive budget, $19.5 million. And the reason we put that out there is just this is a number that will continue tracking for Pmac and the Coordinating Council, particularly as we get to the point in the future where we're looking at the future HEM program and getting ready to kind of get that project off the ground. We will take a look at the health engagement model incentive budget as one of the factors in building out that program. Okay, so with that said, I will stop and open it up. Are there any questions? I obviously did not do this as artfully as Ollie would as the budget expert. And I still think for a lot of lay people like me even, trying to understand the difference at any 1 minute between those two budget tests can get confusing. I mean, the long story short, though, is really the core benefits are something that the board manages through that annual renewal process, where every year we're looking at the benefits provided, the relative costs, and trying to manage each of those plans under that 3.4%. Gayla?
So question about that amount for him. So is that so do we know how much of money goes out to people? Because I know that you get a certain amount, you know, that you're using HEM that you get in your paycheck each month. And so is that part of what that, you know, 19 million? And so do we meet up to the max of that, or is there money left?
Yeah, so that is what the budget is specifically for those incentive payments. So that $17.50 for participants goes into that the budget incentive or the incentive budget, if that makes sense. So it doesn't include all the other extraneous costs related to the health engagement model. So whether it's admin cost or those sorts of things. Does that make sense?
Yep, thank you.
Brian, there is another question in the chat. See, what is the budget for the EAP? Kelly asks.
That I will have to follow up with the group. I'm not sure what the future budgets or what our plans are for how we allocate those funds. And I don't know whether that is an item that is, or whether that is budgeted as a line item or whether it's wrapped into a larger pool that we can kind of work within and shift funds between. So I think we'll have Ali come back, unless Damien, unless you know off the top of your head, but if not, I think we'll just have report back at a later meeting. Okay, other questions? Okay. So Cindy,
really quick, Brian,
yeah.
So with that amount that for the EAP, because I think the agencies pay a premium, don't we? Aren't we all billed a certain amount type thing?
So Gaelic, EAP is different from HEM. So EAP, there is a per employee per month charge that participating agencies pay for EAP services. And you get to choose between a 3-visit model and a 5-visit model, and you get some other stuff as well.
Okay.
The HEM, the figure, the 19.5 million figure I showed that's just what we paid out to state employees who participated HEM for the incentive payments.
Right. Thank you.
Okay, so with that, Cindy, I know we're down close to time. So do you want to just kind of provide some high-level information about what we're getting ready to do for open enrollment?
So you didn't want me to go through my whole 20-minute presentation. I'm just kidding. I'm just kidding. It wasn't going to be that anyway. Sure, I will share my screen, and thanks for leaving the best for last. I genuinely appreciate it after all that information, how engaged people are going to be. I'm going to go off camera though, because it's easier for me to look at what I'm doing. So there's the screen. So I'm just going to really quickly go through our open enrollment timeline. We are knee deep into preparing for our open enrollment materials. We have our webinars scheduled already. We have one for the agency head or agency administrators. So we give them kind of the view of what's coming up for open enrollment, answer any of the questions that they have. And then in October, we do one for members. So I'm sure you're all familiar with that. We have a sneak peek that will come out. It's actually, it says August here. It's going to come out September 1st, and that covers what's new for the upcoming plan year. We will do a very detailed email coming out in September that kind of goes through what all of the instructions, where people can find resources for open enrollment, things like that. The one thing that we do mail out to members is the summary of benefits mailer. That's the side-by-side comparison document that shows all of the plans side by side, like I said, so people can actually have that in their hand and see it. The open enrollment guide is online. It has been since COVID started, and so we have just continued that. We will have an English and a Spanish version that will be posted in September. We have a printable PDF, so if people want a paper version, they can print it, or a ZMAG version where they can just go to the table of contents, click on what they want to look at, and it takes them right there. Posters are available for agency offices, and as always, we'll send informational and reminder emails throughout the process, trying to balance enough but not too many. I am just going to very briefly give a plug for, if I can go to, there it is, our second annual virtual benefits fair. I won't go into a lot of detail on this. Hopefully you accessed this last year. If not, we still have, here's the URL for the 2022 version. It's posted out on our webpage, and I'd encourage you to go out and look at it. All the carriers have a room, as we call it, that there are videos and resource information so people can go out there and get some information about open enrollment and decide which plan is best. And I'm a minute late, so if you have questions, though, I'm happy to answer them.
All right, so I'm looking at the chat. Once it opens up. Okay, and I don't see any new questions. So if there are no questions, I want to thank the presenters for presenting today. Great job, and thanks for all the engagement and discussions, especially earlier on with our short-term work. Reminder, if you're interested on serving on that strategic work group on the PEB member well-being framework, please email Teresa and myself. And if no one does, we just may send you guys an additional email soon to try to get some volunteers. And with that said, thank you, everyone. Have a good, safe, and restful rest of your day, and take care.
Bye, everyone.
Thank you, guys.
Bye, thank you.
Bye, thanks so much.
Bye, thanks.
See ya.